So we're finishing off the day with another angle of pain. Dershnee Devan is an occupational therapist with 27 years of clinical experience and a research interest in chronic pain. She has several postgraduate qualifications, including a master's degree in the field of pain. She's held several leadership positions with Pain SA and the Occupational Therapy Pain Management Group. She's the owner of The Pain Coach. It's a company specializing in the mentorship and training of clinicians in the field of chronic pain management and the host of Pain Bites, a podcast on the lived experiences of pain. Dershnee, welcome.
Hi, everyone. Okay, so today we're going to talk about persistent pain, and specifically I'm going to talk about the roles of sleep, stress, and trauma, and how these affect pain. So this slide is just all my details, and the reason I'm giving it to you is I have a few articles, some resources and some sites on my slides, and if you want the information or the articles, please just contact me, let me know, and I'll send it to you. Okay, so I just wanted to give you some information on what I do, because whenever I say pain coach, people are like, that's weird, what is it that you do? So this is part of what I do. I actually run a few courses, starting off with basic pain science, so you understand the pain mechanisms, and then going into pain assessment in depth, and then there's 2 courses on the pain management itself, and then a few more complex courses on things like complex regional pain syndrome, because the pathophysiology is actually quite different from other pain syndromes, trauma and pain, and then looking at injustice, which is very relevant if you work with people who are injured at work, road accident fund claims, insurance claims. Anybody who's got long-term pain has a sense of perceived or pain-related injustice. And then there is also qualification, where it's a mentorship program with knowledge and skills and resources and case studies. So just some other exciting things that I'm doing coming up. These are all free events. We're doing a coffee chat, if we could put it that way, at Jackson's Real Food Market. I'm doing this with Gary Jackson, where we're looking at lifestyle strategies and how we can actually help people recover when they have pain, inflammation, sleep or stress disruptions. And lastly, but not least, this is something I'm holding every month. So we're doing 10 of these a year. They're free, completely free for any of you that have patients with pain. They can come to these. We call them pain cafes. And what happens is they sit down with a cup of tea or coffee or a cool drink, and we talk about pain, and I teach them a self-management skill to help them in their recovery journeys. Okay, so let's get started. So we're going to talk about pain and whether it's a symptom or not, its relationship with sleep, the influence that stress has on pain, and how trauma unlocks chronic pain. And then I'm going to end off with a case study that's hopefully going to show you how this works. So acute pain we're all really, really familiar with, right? This is the pain we know. It's easy to understand. It's easy to treat. We can identify the cause. It's often biomechanical or disease-related, and it resolves. It goes away. This is definitely what we would call a symptom, okay? This is our body's defense mechanism. It's protective. Persistent pain, on the other hand, persists usually for longer than 3 months. We can't always find a cause. We can't always find what's wrong. Where is it coming from? We can't pin it down. It's often disproportionate. It's subjective, or we consider it subjective, and it has comorbidities. This type of pain doesn't go away. It does not resolve, ever, okay? And this we consider to be more a disease, not a symptom. Because there are neurophysiological changes that happen within the central nervous system. There are characteristic signs and symptoms. There's pathologic neurodegeneration, and there is an etiology and a prognosis. So it's not just a symptom. And the ICD-11 coding system that was introduced in 2019 by the World Health Organization has a whole diagnostic classification for pain now. And it goes from chronic neuropathic pain to chronic widespread pain, which you would know as fibromyalgia. So Chris Eccleston introduced this model of pain, which I think is quite useful. On level 1, we have a physiological homeostasis that there's no awareness of pain per se. And this is what we call nociception, is when you have an unpleasant feeling. It's not really pain yet, okay? Level 1. Then level 2 is where it actually interrupts into your awareness and it urges very specific protective behavior. So this is when you have a headache and you go get the Panado, right? Or you sprain your ankle. So level 1 and 2 is very much still your acute pain situation. So you have nociception in action. And then level 3 is what we call dissociative defense, because here the pain has persisted, it has become chronic, and there's a departure. People lose their roles, they lose their identity. Why? All of this happens because your body wants to protect itself. It's about defense, it's about safety, because there's danger and threat to tissue. So when pain persists, it interrupts to prioritize protection, it interferes with activity, both of which happen during acute pain. But when it becomes persistent pain, it reduces quality of life, it alters people's identity, okay? And we're going to talk about sleep, stress, and I've added trauma to the pain cycle. So why is sleep important? So this is a systematic review and meta-analysis that was done with 31 studies of 699 healthy individuals. Nothing wrong with them, they did not have pain. They basically deprived them from sleep. And what happened is all of them, or a majority of them, presented with an increased pain intensity and a worsened peripheral and central sensitization. And these are healthy individuals. So basically, they didn't let them sleep and they produced pain. Okay. So now I want you to think about your patients with insomnia. Okay. So if you don't sleep well, there is a very, very good chance you're going to develop pain. And sometimes that's going to become persistent pain. So let's look at this bidirectional relationship that sleep and pain have. So what has been shown, and this is another meta-analysis systematic review where they've looked at over 1,000 people and they've looked at 83 associations between pain and sleep. And poor sleep quality gives you a higher pain intensity, okay? And if you have high levels of pain, you will also have an impaired sleep quality. But what they've shown consistently is that if you don't sleep well, the pain that you feel the next day is worse. And I can tell you clinically, I see this with my patients. If they don't sleep well, their pain is worse the next day. So the consequences of this chronic sleep pain interaction is there are comorbidities such as depression, anxiety, it affects self-esteem, it affects immune function, it's a cardiovascular risk, there's impact on relationships, on social interaction, on intimacy, on their quality of life, their everyday activities, their ability to work. So if we don't sleep well, you can't really concentrate well the next day. And that affects finances, loss of work days, and eventually can cause disability as well. So this looks very specifically at the pain-sleep cycle and why it's difficult for the body to actually come back to homeostasis. So what happens when we don't sleep well is it affects our endogenous pain modulation. So we are unable to inhibit pain. Pain is facilitated through the processes. There's greater inflammation through IL-6 and CRP. It affects mood and other states, creates emotional distress. It also affects endogenous substances like orexin, cortisol, melatonin, dopamine. And the anatomical brain areas involved in this is nucleus accumbens and the periaqueductal gray, both very much involved in processing and modulating pain, as well as the cyclic patterns that exist when we sleep. So what essentially happens is it amplifies the reactivity in the sensory cortex, it lowers the pain threshold, the anxiety, the mood, the depression mediate the relationship between pain and sleep quality. So the less you sleep, the more anxious and stressed you are, the more pain you have, the less you sleep. So from a patient experience point of view, what they experience is they feel a loss of control because they're unable to sleep and they have pain. They can control neither. It creates anxiety and emotional distress. They have really poor sleep quantity and quality. They start napping excessively. They start resting all the time, results in more stiffness and deconditioning, and eventually that leads to functional impairment and disability. So clinically, what does that mean? It means that we need to address sleep because sleep will help the pain experience. And we have to do this through physical interventions, things like exercise, sleep hygiene, through psychological aspects such as CBT, because we have to disrupt the pain-sleep cycle. And if we do that, we can improve the pain experience and improve function. And then we'll talk about stress. So stress and pain also have a really close, intimate relationship. They trigger each other. They can worsen each other. Chronic stress and chronic pain versus acute or chronic stress and pain both have similar relationships. They affect each other's intensity. So essentially, if you have stress, it makes things worse. If you have pain, it makes your stress worse. Your thoughts and beliefs about stress or pain also affect the other. And again, if it continues and it is chronic, it becomes reduced well-being and disability. And it's important to note that when you have significant pain, the pain itself becomes a stressor. The pain itself stresses you out. Remembering that stress and pain activates the autonomic nervous system and the HPA axis, and it increases the physiological allostatic load in the body. So if we look at this stress-pain cycle again, it has three components. There's a cognitive behavioral factor component that has pain anticipation, the hypervigilance, the inability to stop thinking about it, the negative thoughts, the beliefs about how much activity they can do, can they recover. Then there's also environmental factors like the social support, lifestyle, environmental factors, and physiological factors like neuroendocrine dysfunction, the maladaptive neuroplasticity, and chronic inflammation that then results. So we all know that we experience stress on a daily basis. All of us do. All of us do. But usually what happens is you have an adaptive response and you return to baseline and you recover. That's what happens repeatedly. However, when we have fear-based stress and it happens repeatedly and we have what we call a sensitized fear-based memory and pain enters the conversation, that negative thinking pattern continues. And if we have stress that continues and you have a prolonged and excessive activation of your HPA axis, basically what happens is you have a dysfunction of cortisol. This affects the amount of inflammation you have in your body, creating chronic inflammation, pain, and affects depression as well. And once we have chronic inflammation, this sustains pain and it impacts mental health. We have neurogenic inflammation, where that actually drives the persistence of pain. We have systemic inflammation that is associated with depression, anxiety, fatigue, and mood disorders. And we have psychosocial stress that contributes both to inflammation centrally and peripherally. And these psychosocial contributors are quite significant. So this is the fear avoidance model of pain. And basically what we're saying is we experience pain, but then we start to have these negative thoughts about it because the pain isn't going away, right? You have a fear of pain, you develop this helplessness, you can't get better, anxiety, hypervigilance, and there's a stress response. And all of this results in functional impairment and disability. Health anxiety contributes, their beliefs and their expectations, their unfairness or injustice they experience, and obviously trauma and stress are contributors. And then we have something called threatening illness information. Now this is interesting. So your friends, your family, healthcare providers, your community will provide information that can be actually quite threatening. Because they will say things like, you've broken your back, you'll never be able to walk again. You can't go back to work. You can't pick up things again. This is, you're damaged, it's over. So we have to be really careful in how we talk to our clients and patients, because we do influence this process, in their brain and how they think about things. So there's also environmental, lifestyle, and social factors that affect the stress-pain relationship. So having a low socioeconomic status, obesity, poor social support and isolation, sleep disorders, which we've talked about, inactivity, not moving is a big problem, and substance abuse is often a comorbidity. So basically, if we address the stress, it will also help the pain experience. Because if we reduce stress, it improves the pain experience and it improves function. So let's talk about trauma. So trauma exists on a continuum. We have adversity on one side and trauma on the other. And there's a difference between people who have post-traumatic stress symptoms versus post-traumatic stress disorder. You have unresolved trauma that is quite significant. If you have repeated unresolved trauma, it actually rewires your nervous system. So the distress is quite significant. So we have risk factors. If you're older, your risk factor of developing pain post-trauma is higher. If you're a female, it's higher. If you have a higher acute pain intensity in the event, whatever that was, if it was an injury, and if you have already got anxiety or depression, you're predisposed to developing pain post-trauma. But there are also protective factors. So if we intervene early when someone experiences trauma, if they have a sense of they can get themselves better, they can do something to make themselves better, and if they're accepting of their pain, then it is protective that they are more likely to not develop persistent pain post-trauma. So trauma triggers a complex physiological cascade, biological and psychological changes, and it actually causes acute pain to transition to persistent pain. What are those mechanisms? The neuroplasticity, central sensitization, and neuroinflammation that occurs that cause actual cortical changes in the brain. And that's what causes the acute pain to transition to a persistent pain. So those factors that I've spoken about already in terms of pain intensity, anxiety, depression, negative thoughts, but also a prior trauma experience. So if you've experienced trauma previously, it will predispose you to developing persistent pain. So these amplify your pain perception, they create hypervigilance, and they create negative beliefs regarding pain as well. So basically what happens is, this is pain, but in survival mode. You have a recalibration of the pain processing system, an alteration in the brain's ability to filter information, an increase in stress hormones, and a reduced immune response. It affects their sleep, their anxiety, their fear, they develop hypervigilance, and obviously the PTSD or post-traumatic stress symptoms. It affects their social interaction, their work participation, their social connections, and it affects their relationship with you in terms of a therapeutic relationship that you might have with them. Because trauma shapes the way individuals relate to and experience their body sensations. So how do we manage this? We all know about early intervention and referral. Well, we need to practice it. The other thing that needs to happen is that patients or clients need to take active roles in their treatment and rehabilitation. If they are passive participants and expect you to continually do to them, they won't move forward. There needs to be validation and acknowledgement by us, by their families, by their community of their pain. And our therapeutic relationship or alliance with them is quite important. We need to show empathy, kindness, acceptance of where they are. We need to meet them where they are, and our messaging is quite important. And if we get this right, they will develop coping skills, they will have a positive interpretation of their pain, and they will have optimism for recovery. But this is quite important, and that's why I thought I need to mention it. Having a GP who listens and understands and treats me with respect is very important. It's a really old quote from a really old study, but it is relevant and will continue to be relevant because the gap between a health professional's point of view and the experience lived by a patient is significant. We don't really know what they're going through. We need to listen to understand. We must not categorize them. We must honor their accounts and respect and support them. Trauma is associated with the persistence of pain. Early intervention referral is key, and you have to treat more than the biology or the psychology. Safety is important. They have to feel safe. If they're safe, they will trust you and prevent the persistence of pain. So I'm talking about why OT, because I often get asked, why is an occupational therapist treating people with persistent pain? Well, people with persistent pain have problems with sleep, self-care, work, activities of daily living. They have problems with their emotional well-being, and they have problems with function and coping strategies. And that is exactly what occupational therapists deal with. This is what we do. We're holistic and we're biopsychosocial. So it's about helping people understand their pain, helping them to engage in mindful strategies, helping them to pace their activity and create routine and structure in their lives, and activating their meaning and purpose, teaching them to breathe, basically. So I'm going to go on to a case study because I think nothing demonstrates this better than actually a real-life patient. So this is a 31-year-old single female. She had a hospital admission post-suicide attempt, so there's the trauma. Completely numb, foot on awakening in ICU from her knee downwards. She had physio, she mobilized, she was independent in mobility when she was discharged. She then had outpatient rehab, and 2 weeks later, she developed a burning, persistent pain. She actually had to stop physio because she couldn't manage physio. It was too sore. They put her into a splint. She was then readmitted and had an epidural and nerve block, and diagnosed with complex regional pain syndrome and referred for rehab on discharge. That's what her foot looked like. She had poor sleep, swollen foot, discolored, and if she flexed her foot, she had burning pain. She couldn't weight bear on it. She mobilized on crutches. Her warm water made it worse. Cold water improved it, interestingly enough. Hypersensitive, if you touch the foot, really hypersensitive. And she literally woke up several times at night to put her foot into a bucket of cold water. So she wasn't sleeping. She was just dousing her foot in cold water. She was stressed and fearful about her work and function going forward. When she presented to me, she was attending psychology and psychiatry regularly. She was on pregabalin, a tricyclic antidepressant, an SRNI, an opioid analgesic, an anticonvulsant, and an NSAID. And she was unemployed. She had left work because she could no longer work due to pain. She's 31 years old, remember, guys? She's young. Okay, so these are the outcome measures I did when she arrived. We have a diagnostic checklist for the complex regional pain syndrome, and she was positive on that. She was also positive for neuropathic pain. I did the DN4, which is a neuropathic pain outcome measure. And then I looked at her pain severity, which was moderate, and a pain interference score, which was also moderate, and both of those are significant. And she reported that sleep, walking, work, and general activity were the areas that she really didn't cope with. And her level of central sensitization was 39, which is mild, but our clinical cutoff point for that is 40. So I don't know that 39 is that mild, to be honest with you, given her presentation. What did we do? So her psychiatry and psychology continued, and she was still on her meds. But we actually did a lot of basic pain science education with her, helping her understand what was happening in her body, helping her understand the mechanisms. And then I did some sensory re-education to help her regulate her sensory function in her limb. I did graded motor imagery with her, which is a 3-phase program that actually looks at reorganization of the cortex and how do we normalize that. Sleep hygiene and targeted her sleep routine, etc. Graded exposure to activity, so we had to very carefully reintroduce her to physical movement and activity to target her stress and fear. We helped her with activity scheduling and graded participation, some goal setting, and eventually she started swimming as exercise. And this was her on reassessment. So she improved significantly enough to then be negative on diagnosis for complex regional pain syndrome and negative for neuropathic pain. So for neither of those was she positive. Her central sensitization went right down to subclinical. Her pain severity decreased to mild. Her pain interference was still moderate, but if you look at the scores, they all came down except for walking. And when I investigated that, she said to me, because she was now walking independently, she was wearing shoes, etc. She said, well, I can't wear certain type of shoes, and I still don't believe I'm walking well. So that's why I left it as a 10 out of 10. And that's what her foot looked like. So the outcomes were she had full activity participation. She was driving, swimming, bathing again, running. She started gradually, went to physio for lower limb strengthening. She got a job, and her sleep improved significantly. Why did the treatment work? Because we decreased the sensitization in her body, both centrally and peripherally. We decreased the amount of neurogenic inflammation, and the inflammatory process was targeted. We normalized the cortical representation of her limb in her brain. We helped improve her psychosocial factors, her stress, her fear, her hypervigilance. We improved her activity participation, her sleep, and gave her psychological support. So often this is what we think recovery looks like. That picture on the top, you know, patients and us as healthcare providers believe that we go from A to B and we go there really quickly with an intervention, but that isn't how it works when you have pain, and particularly when you have persistent pain. We have hills and valleys, we have ladders, we might have a few lakes to swim through, some bad weather on the way, and we get there, we eventually get there, but it's longer and it's a much more difficult road. And it really is all about restoring balance and homeostasis for that person. So this is what I often see, is that the medical team is tired of these patients. You don't want to see them anymore. You don't have any solutions for them. You see their name on the list and you're like, oh no, not that person. No, not today. Right? That's the attitude we have. We just want to get them out, in and out as quick as we can. And the problem is that the patient and family is confused. They're doing everything you told them to do. They're taking all the tablets. They're having the intervention. But their pain ain't getting better. Right? And so the solution is not that, but we're all in the same boat. Us, the treating team, the family, the patient, we're in this boat together. And we have to work together to stop going over the waterfall. Otherwise, you will have a patient with persistent pain. You've got to put the patient in the middle of this discussion, and you've got to work with them to get better. So, it's if you need help with anything pain-related, there's my QR code. Or if you want to send patients to events, or if you want referrals for your area, I have a wide network of other professionals we use. But we have to work together with our patients, and our patients do come first. Yeah, that's it.
Thank you, Dershnee. Let's give her a round of applause first. Anyone on the floor with questions? Okay, I just wanted to... Wow, there we go. Let's go.
Thank you. The management you displayed looks very complex.
Yes.
Roughly, what's the cost at the end?
The cost is a holistic team approach. Okay, so firstly, they have to have a doctor who understands them and who knows what they're doing. So sometimes that can be their treating team doctor, whoever that is. Sometimes it requires a pain specialist. It really depends on the level of pain and the persistence of pain. Then an occupational therapist. Sometimes we have a physiotherapist or a biokineticist as well, depending on what's happening. And then a psychologist at times. So we don't always use psychology because often people with pain don't want to go and see a psychologist. If they come to us with a psychologist, then they're often happy to continue. If we feel they need psychology, it often takes us some time to shift them. So yes, it costs whatever people are willing to pay for healthcare, because in this country it's medical aid, that pays and doesn't pay, to be honest. As you've heard, medical aid doesn't really pay for the treatment that we need to give patients. I would say that I see somebody for 3 months before I can tell you that there's no way I can help someone. And that's really not that expensive, to be honest. Yeah. It sounds complicated, but we do a lot with the time that we get. I never see a patient for less than an hour. So my treatment sessions are an hour long. Yeah.
Do you think that the BWRT and brain spotting and some of the modalities that Janine was talking about might be valuable?
Yes, particularly if they've got trauma and stress. Absolutely. And anxiety. And a lot of my pain patients have trauma, stress, and anxiety.
Yeah, sounds good. Anyone else? Yes.
Yeah. Thank you very much for a very informative presentation. Yeah. On your case study, did the patient's symptoms have anything to do with her initial suicide that she was admitted for? And how long did it take you to get her?
She had, I think, if I'm not mistaken, she had overdosed on medication, and they'd then admitted her to hospital and, done the whole procedure in terms of sorting out that. But no, the symptoms were not related to the suicide attempt, because when she was discharged, she was mobilizing independently, and there was no pain. So on discharge, there was no pain. It was 2 weeks later that the pain happened. We did think that possibly while she was in ICU, there was maybe a needle stick injury from a drip or something. That's what we were thinking, but we don't know, because the hospital didn't report any injuries at the time. Yeah.
Thank you. My question is about a patient living with a chronic pain, but with an existing organic conditions, let's say a sciatica with disc prolapse, offered surgery but doesn't want to go for surgery, will be living with chronic pain. Can this also help manage?
Yes, so remember, if they've got organic pathology and biomechanical problems, we fix that for as much as we can, or as much as the patient allows us to in this situation. But coming for a very specific pain management rehabilitation approach with a physiotherapist and occupational therapist will help. How will it help? It helps them become more functional. It helps them to self-manage their pain, to self-regulate. So I can tell you that most of the patients I see, when they come into me, they're very dysfunctional. They're not coping and they're not functional. They're usually in bed or on the couch. And by the time they're done with rehab, their pain doesn't go away. We don't take their pain away. We improve their function. We improve their independence. They learn how to live with their pain and how to manage their pain better, how to manage their flare-ups better. That's where the focus is. We cannot take away their pain because once pain is persistent, it is there to stay. They might have days or moments where they're pain-free, but they are never pain-free again for the rest of their lives.
I suppose that's case dependent as well.
Yeah. Yes, it's case dependent, yeah.
Yeah, just one question. The role of family support, how much of it and what percentage does it contribute?
Yeah, it's very important, eh? It's very important. So the social context around pain is really, really important. Not just family, the work environment, community, church, all of that comes into it. So I've seen time and time again where the social context actually disables the person. Not, everything else is working, but it's the social context. So having a partner that doesn't understand and doesn't support you. Or we have the opposite where the family and the partner are over supportive. They actually create the dependence. Don't lift that dish. Don't wash yourself. We're going to bath you. We're going to do this for you because now you're ill and now you're sore and you can't do things. So it's on both sides of the coin. They can make it worse, but they can also make it better. So when we have families and partners and even works of our environments that are supportive, accommodating, understanding, and they acknowledge the person's pain and they validate them, they make the biggest difference. The worst part is to have a partner or a family that does not validate or acknowledge that person's pain experience. So part of what we do as a rehab team is we often meet with the family and we explain pain to them so that they understand what is going on. Because remember, as a layperson, our understanding of pain is, I have a headache, I take a Panado, it gets better. Now I took the Panado and it's not getting better, right? So for them, they're like, but she's taking her medication, she's had the surgery, why isn't she better? There's something wrong with her. She's lazy, man. She's lazy. She doesn't want to do this. She just doesn't want to work. She's lying in bed. What's wrong with her? So it is really about helping people understand the pain is real and why it is there.
Can you tell us a little bit more? I'll come to your question now. Can you tell us a little bit more about Pain SA and perhaps the upcoming conference? Because we've heard about it from you as an occupational therapist.
Yes.
And from Sean as an anesthesiologist.
Yes. So Pain SA is a great organization. I've been going for years. I was on the Expo for some time. The next conference is here in Joburg at the Indaba Hotel. It's the 22nd to the 24th of May, I think. And literally we get together for 2 to 3 days and we talk about pain. It is a multidisciplinary conference. So doctors, physios, biokinetics, psychologists, specialists, anyone who has any need to come to the conference to understand pain, to learn about pain. We try and include clinical topics. There's also science topics. There's research topics. It's just really, really good if you want to learn more.
And CPD. Yeah. All right, our last question. Thanks, Janine.
It's just an interesting comment you had about getting your clients to see psychologists.
Yes.
I'm sure they must have heard it's all in your head, right?
It's
all in your head. It's like you're just imagining it. And I don't know if that's part of why there's this resistance.
Yes. So that is exactly it. So the problem is that a lot of doctors and other healthcare professionals tell people with pain, specifically if they've got persistent pain, that it is all in their head, that now it's psychological and there's nothing they can do for them. So yes, that is definitely a bias and a stigma that some people come in with, but we also have patients, remember, again, a layperson's understanding of pain is black and white. I have a headache, I take the Panado, it gets better. So we often have patients who believe that there's just this one thing that they need, this one tablet, this one type of doctor, this one type of intervention, and if they have that, their pain will disappear. It will go away. And when it's that kind of patient, they definitely don't want to see a psychologist. Yeah.
It's a tricky one. All right, Dershnee, thank you very much for spending time with us today. This is for you. Really enjoyed having you here, and yes, seeing pain from a few different perspectives is very interesting, and I think attending something like Pain SA maybe once every couple of years in your career might be very useful because most of us deal with pain.